Hello everyone, I'm Rahul Gosain, here with my brother Rohit Gosain. And today we're going to focus on how fast the field of bladder cancer is moving. Just before this discussion, we've seen press release from Potomac where our patients are now going to be living longer, even in early settings of bladder cancer. Last year, we saw data from EV302 with overall survival doubling. And early on, we saw approval of Durvalumab in muscle-invasive bladder cancer that can be resected. Our focus is going to be on that population, that subset, because now Durvalumab is the new standard of care. For this, we're joined by our two medical oncology colleagues, Dr. Karine Tawagi and Dr. Petros Grivas, and two urologists, Dr. Joshua Meeks and Dr. Neal Shore. Karine, can you start us off here? In muscle-invasive bladder cancer, where you can resect the bladder, our treatment paradigm has been chemotherapy, surgery, and then adjuvant immunotherapy. With event-free survival and overall survival, now we have Durvalumab. Here we are. What's the current paradigm in this patient population?
Absolutely. So I think when we're thinking about muscle-invasive bladder cancer, I also just want to mention that we can also think about chemoradiation for select patients. But then when we're talking about patients that are fit for surgery, the main question is, are they cisplatin eligible or not? So we know that we do not have any perioperative chemotherapy for cisplatin ineligible patients, but we have had two regimens that have been approved for cisplatin eligible patients. So we've had gemcitabine cisplatin and then Dosens MVEC. And then in the last few years, we've had approvals for adjuvant immunotherapy for patients that either do not receive neoadjuvant chemotherapy or have residual disease at the time of cystectomy. And those approvals are based on the Checkmate 274. We have 1 year of adjuvant nivolumab, which met its disease-free survival endpoint, and then had an interim analysis earlier this year favoring overall survival data. And then we've also had the Ambassador trial looking at 1 year of adjuvant pembrolizumab, which has met its disease-free survival but not overall survival endpoint so far. We've also had a negative study looking at adjuvant atezolizumab. But where we are today as far as the standard of care for cisplatin eligible is with the NIAGARA trial, which is adding Durvalumab to that gemcitabine cisplatin in the neoadjuvant setting, but then also giving 8 cycles of adjuvant Durvalumab after cystectomy.
Thanks for summarizing that. Where we stand today is, again, this is now the new standard of care. NIAGARA trial, since the presentation of Dr. Tom Pells back at ESMO 2024, has changed the standard of care that particular day. Petros, with regards to the NIAGARA trial, we have seen the results from ESMO 2024 and recently from GU ASCO 2025. If you could please summarize the trial design and its findings from those two settings.
Thank you, Rohit. And I have to say, this has been a great journey to see the treatment paradigm changing and better outcomes for our patients. So I'll try to summarize it briefly. The NIAGARA trial has been a study that was a huge lift. It was designed many years ago before the pandemic, and it was a trial that when it was designed, we did not have a great track record in accruing in adjuvant trials, at least. There was a European effort that did not accrue, so kudos to the investigators. The design was neoadjuvant GemCis, 4 cycles of standard gemcitabine and cisplatin, as Karine pointed out, with or without neoadjuvant Durvalumab. Durvalumab was given with GemCis as part of the 4 neoadjuvant cycles, and then in that particular trial, Durvalumab was continued adjuvantly, regardless of the pathologic stage, and we can come back to that in a second, for 8 monthly adjuvant doses. Patients in the control arm, neoadjuvant GemCis, did not receive adjuvant immunotherapy. The trial finished accrual about a month before adjuvant nivolumab got approved in the US by the FDA and several months before it got authorized in Europe by EMA. So the big question is, what would have happened if adjuvant immunotherapy was to be given in the control arm? Hard to tell. And of course, the other relevant factor is what treatment patients may have received if they had a recurrence in metastatic disease, because this access can impact OS. Overall, the trial showed a significant event-free survival and overall survival benefit with addition of Durvalumab perioperatively, so both neoadjuvant and adjuvant, again, regardless of the pathologic stage. And of course, it's very exciting to see overall survival data and benefit with an agent in the neoadjuvant adjuvant setting, because we know it's a high bar, and the previously conducted trials in the purely adjuvant setting, Ambassador or even Checkmate 274, have not as of yet shown a conclusive OS benefit. So I think despite the caveats that are inherent in study design, the trial is practice changing, and I think that corresponds to the regulatory approval. We have started to use this in the clinical practice. The last quick point I will make, and of course, Josh did a great job at a recent AUA meeting, showed some important data that he can talk about regarding the particular subset of patients and also pathological complete response data. The path-CR is very hard to interpret in the context of a study that can influence by the clinical stage, what we think the clinical stage was at the time of enrollment, of course, of the completeness or extent of the URBT, how hard you look in the bladder. So it's not a very reliable endpoint for regulatory approval. We need a time to event endpoint. And the last thing I would say is that in terms of safety and toxicity, addition of durvalumab did not compromise the ability of patients to undergo curative intent radical cystectomy. So overall, based on all the above, I think it's a practice-changing trial. And as I mentioned, Josh did a nice job at AUA doing some final, at least, updates regarding the path-CR and the subset of patients with this borderline creatinine clearance, because the trial allowed the GFR to be down to 40 ml per minute, which is different than the classical GALSI criteria, which use 60 ml per minute. So it's a big discussion where you put the bar, your threshold for kidney function creatinine clearance, but the trial specifically was for cisplatin eligible patients.
I want to reiterate something here, going back to that cisplatin eligibility criteria was expanded here. One, which we often use, but here 40 to 60 was also used, and we'll touch on this, the outcomes were not compromised. Petros, as a community oncologist, we're often relying on NCCN guidelines. This is approved, this is part of NCCN guidelines now. Where does it sit in terms of the recommendation as part of NCCN guideline?
I think based on what we discussed, this has level 1 evidence. So if you have a patient in the clinic who is fit for cisplatin, we can discuss about the creatinine clearance threshold. It can vary depending on who you talk to. For example, in that trial went down to 40 cc per minute or higher. Some other folks may go to 50 or higher depending on your threshold. But if you think the patient is eligible for cisplatin and has no contraindication to get the checkpoint inhibitor, personally, I think that the NIAGARA regimen has level 1 evidence, and I think it should be considered in patients, again, who can tolerate this treatment. One side note, personally speaking, Josh and me have talked about that, I tend to use dose-dense MVAC with growth factor supporting clinical practice. Overall, compared to GEM-CIS, there is no strong data comparing the two that shows significant evidence of benefit with dose-dense MVAC. But if you put everything together, to me, it looks compelling. So if I had the chance, I would use dose-dense MVAC with growth factor plus durvalumab, if insurance can approve that. And there is some phase 2 data supporting that approach. But based on, from a purist approach, based on the NIAGARA regimen, GEM-CIS durvalumab is a standard of care with level 1 evidence based on the NIAGARA trial.
Right. Thanks for summarizing that, Petros. And Josh, we will come down to the AUA aspect of the data you covered, but before we go there, Karine, if where we stand right now is this perioperative neoadjuvant chemo to be given for 4 cycles. Now we know that we are dealing sometimes with an attenuous population with this eGFR between 40 to 60. If you do get them started with a split cisplatin dosing in this setting, and they only get 2 cycles, they develop toxicity where we cannot continue on with the chemotherapy. Do you still give durvalumab for 2 more cycles, or go for surgery and then add durvalumab to complete that 8 plus 2 because that's what got missed initially?
Yeah, that's a great question, and I'm not sure that the trial teases out that question. I think it would be a multidisciplinary discussion with our urologists as far as do they have the availability and do they feel like based on the size of the tumor initially, they can get a good response with cystectomy. So I think it would be case by case depending on the extent of the tumor. And maybe you would consider restaging after 2 cycles and see where you are to decide, I think if there was going to be a reason that the cystectomy had to be, still scheduled at the same time, I would probably still proceed with durvalumab, just so that they get some form of therapy in the meantime if they're unable to get more GEM-CIS.
Can't stress the importance of multidisciplinary in this particular setting, though it should be utilized in a lot more as well. But again, in this particular setting, urologists and medical oncologists should be on the table itself to make these decisions. Josh, with regards to AUA 2025, what you presented was this particular subset population of eGFR 40 to 60 with regards to the path-CR and EFS. What was seen and your thoughts here?
Yeah, so the update that we gave at the AUA, part of it was the disease-free survival, which is the cystectomy population. And I think that's a critical group because that's what a lot of people have compared to, for example, with Vesper, which was just the cystectomy population. And in that point, we talk about the path CR, which was 42%, which essentially is equivalent to what Vesper is. And again, it's the same. The hard thing about comparing across trials is, again, the numerator and the denominator. But in here, these are the people who got a cystectomy, and that's around 80% of the overall ITT from NIAGARA. We also did report on the 19% of patients that had a reduced GFR between 40 and 60. Path response, 32% compared to 16% in the control arm. Event-free survival was essentially the same hazard ratio as you get in the ITT. So I think, again, as surgeons, we like to be aggressive, right? We're taking a patient and trying to put them through probably one of the more challenging surgeries that is offered. So we like our medical oncologists to be as aggressive, and so we love it when they're willing to try to get patients through that. And I really think that NIAGARA gives people an opportunity to get the benefit of the checkpoint to add on to a very tolerable chemotherapy regimen.
Neal, can I come to you for talking about this being the new standard of care, but as a urologist, you're the gatekeeper to these patients. How has that conversation changed in your clinic with durvalumab being exposed upfront and the plan to continue with durvalumab? Because setting that stage from the get-go is important. Are we looking at the outcomes in terms of surgery with this approach?
Yeah, I think I just would echo so many of the great comments that have already been made. For many years, there was an underutilization of platinum-based neoadjuvant therapy. And I think that the real world data tells us we see in the community, outside of the much higher standard that we oftentimes see in academic centers, I've seen it really improve in the community to make sure that we're employing for our muscle-invasive bladder cancer patients. We want to stage them correctly, but absolutely before we would go to cystectomy, not rush them off, but give them the benefit of having platinum-based therapy. I think now that with the data from NIAGARA is so compelling, I thought it was great that Josh was able to present it just a month ago at AUA and really have a forum for that. And frankly, the AUA had a lot of bladder cancer. It was really more bladder cancer than it was prostate cancer for the first time that I could ever remember. So I think that baked into your question it's really important, the multidisciplinary conversation, whether it's through a tumor board or just making sure that our uro-oncologists have the patient see the medical oncologist, and now the NIAGARA data, which is now incorporated into NCCN, because it is level 1, as Petros points out, this is the new standard of care. And I do love the fact, 2 key things, at least from a urologist, or really 3 things. One, it really did not distract or deter patients going to cystectomy because of any unusual or new seen tolerability profile. That was great to see that. We see great pathological CRs, and then we also see the ability to bring this to patients with lowered renal function, lower GFRs. So I would just echo what Josh said. This is really the new standard of care. It's very important that we bring this to patients. And for some who say, no, okay, there's always the shared decision-making conversation. The number of patients, it's very small who had to stop and not get the full 4 cycles beforehand, which I thought was really good too.
Right, at least sorry. No, I just want to complement what Neal said, that if you look at the proportion of patients who went to cystectomy, the point we mentioned before, was very similar, numerically slightly higher in the durvalumab arm, again pointing out that the addition of durvalumab was safe, feasible, and did not compromise the ability of patients to get surgery. So I think that's also reinforcing the idea. And the other thing, relevant point that I think you alluded to, Neal, is this a multidisciplinary discussion, and I think getting authorization, for example, up front when you see the patient can save time, and now with the New England Journal of Medicine paper, NCCN guidelines, FDA approval, should be easier for that authorization to take place, and at least let the data guide us in that regard.
And in terms of the outcomes, number of patients that made it through for durvalumab for radical cystectomy was 88%. Numerically, in the control arm, it was 83%. Out in the community, we're seeing this approach for different disease sites, be it now for upper GI or lung cancer. And that is not the trend. Here, thankfully, we're not compromising any surgical outcomes. And I think that's important.
And the most common reason, and Josh, you can correct me, the most common reason of patients do not get cystectomy was patient choice.
Right.
So
Exactly.
that's an interesting whole other discussion. Can we envision a future with better biomarkers, better effective systemic therapies? Could we omit cystectomies? We're not there yet today, but we're getting there. And it's a matter of optimizing systemic therapy and biomarkers.
An added benefit was to add some of these patients with the particular subset of EGFR 40 to 60, which we, at least in community, it was not a hard uptake for us because we have been used to doing split dosing cisplatin. So again, the side effect profile is not being affected that way. Karine, with regards to PAT-CR, this is being questioned because of the fact that in breast cancer as well as lung cancer, we are using perioperative approach. We're always confused, does the adjuvant therapy needs to be added? With PAT-CR versus no PAT-CR here, where does this data stands right now?
Yeah, absolutely. So at ASCO GU this year, we saw updated results about the overall survival, whether you had a PAT-CR or did not achieve a PAT-CR, and there was benefit either way. So I think that helps to answer the question as, you know, what's the benefit of the adjuvant therapy? We can't tease out the real question of, does everyone need the adjuvant portion of the therapy with the sandwich approach? But I think where we stand right now, we have to follow the way that the trial was designed. In the future, if a trial was designed with just the neoadjuvant immunotherapy portion, and then, you know, the control was patients not getting the adjuvant portion versus getting it, that could truly answer that question. But I think based on what we know right now with the NIAGARA trial, I would follow what the regimen in the trial did, which is to give everybody the full regimen in the adjuvant setting as well, regardless of their PAT-CR.
And again, I think out in the community, the clinical practice should be all comers because we saw that benefit. Joshua, so we're not compromising outcomes of number of patients that are going through radical cystectomy. Is their recovery any different if they're getting exposed to durvalumab?
Well, data doesn't suggest that from NIAGARA. You know, again, the time from cystectomy to starting therapy is 8 weeks, right? Same in both arms. You know, the patients, we've actually, it started filtering out when when the paper came out before it was FDA approved, so we started seeing our patients getting it. And really not a difference in what I see on a day-to-day basis in the surgery, in the recovery, in the healing. I don't see that. I think it's just more that, you know, now that you're better, time to go back and check in with your medical oncologist because, you know, now we can start the next phase.
Petros, can you comment a little on that? Once they've recovered after that procedure, what is the timing like when you're initiating durvalumab in your clinic?
Yeah, it's a great point. So we usually have a multi clinic, and we have discussed that with Josh. We have the urologist, med-onc, rad-onc, pathology, radiology sitting in the same room. Of course, that multi model is not easy to replicate across the community, and Neal and me have talked about that before. Having said that, I think you're right to say that as much as possible to have the communication, discussion, you know, between the disciplines. As soon as we see the patient and we think that that patient is a good candidate for cisplatin and can get checkpoint inhibition, we initiate the prior authorization, obviously. And I mentioned before that I use docetaxel as my chemotherapy backbone. I would still use durvalumab if I can get, again, this combination approved. As I mentioned, GEM-CIS is a very acceptable, the most commonly used neoadjuvant chemotherapy, and is acceptable in people who are familiar with using it. That's fine, because familiarity also matters in terms of management side effects. I would say, as Joe said, if you start the treatment and then you complete it, usually patients were able to get radical cystectomy in about within 6 weeks from the end of chemotherapy and checkpoint inhibition, which is what we have seen either with neoadjuvant chemotherapy. So very similar time frame. So usually we tell the patients, we start neoadjuvant treatment, we plan the cystectomy because OR space is limited. Usually we aim 4 to 6 weeks after the end of neoadjuvant treatment.
Yeah, NIAGARA I think was like 5.5. It was right on that.
Exactly.
So that's totally appropriate, which is, you know, good, right? That takes scheduling. That makes a lot of sense. You're ahead of the curve with the MVAC, and, right? So that's NIAGARA 2, right? And so that's on its way. So we'll be excited to see how that backbone compares.
Exactly. And, you know, it's interesting. I say, in my mind, chemotherapy, cisplatin-based chemotherapy specifically, plus durvalumab, I think there is, importance of that combination. You may capture more heterogeneity. You have done great work with molecular subtypes, Josh. I think if you combine the two mechanisms, you probably capture more of that biology of disease. Now we have to see what NIAGARA-2 shows, because I think there's maybe some potential partnership between docetaxel and durvalumab. We'll see.
Yeah, so 15% of patients were variants, right, in this. And so we'll see, again, I think that's where you're trying to pull those people in, which is important, right? Most trials don't include that, so it'd be great to see how they respond here.
Totally agree. And I think we have interest in variant histology bladder cancer, and as Josh pointed out, NIAGARA included those patients, about 15%. I think primary urothelial was a requirement, but I don't recall any percentage or predominance. So it will be interesting to see the data in this subset. I think half of them had squamous cell features, but definitely in the population of interest.
Neal, can I harp you a little more on the outcomes as well? So again, we're not compromising the number of patients that are going for radical cystectomy. Is your practice looking any different in terms of recovery after we've added durvalumab?
Well, not at all in the neoadjuvant setting. I have not seen that at all, and the data bears that out. So that should be very reassuring to the uro-oncologist, the surgical oncologist listening to our program. That should be very reassuring. And then that would be, prior to cystectomy and then after cystectomy. And I think the number of grade 3-4 adverse events was actually, pretty impressively low. So the patients can really get through this. Of course, if a patient's having complications after the cystectomy, that's a whole nother issue, and it's usually something that's a surgical complication at that point. But we didn't see anybody in the study that was not able to get the 8 cycles afterwards.
Karine, with regards to the NIAGARA trial, which is now the standard of care, what we've seen is this improvement in event-free survival and overall survival. How is that conversation with the patients now, given the impressive data?
That's a great question. I think we were having that discussion about the benefit of neoadjuvant chemotherapy before. So now we have even stronger evidence to have that discussion to say, hey, we can give you these 12 weeks of therapy before your big surgery, and we know that will prolong your life based on the results of this groundbreaking study. We also know that in the study, in order to have that survival benefit, most of the patients received that portion in the adjuvant setting too of continued immunotherapy. We know that the side effects in terms of long-term serious side effects from this therapy are very low. I think there were very few grade 3-4 immune-related adverse events. The most common side effects were things like thyroid issues, rash, dermatitis. There was quite a low rate of other serious immune-related adverse events like myocarditis, hepatitis, other things like that. So I think that, as far as patients wanting that survival benefit, that is the selling point in terms of counseling patients. But I think it's still important to talk about the toxicities because, although very rare, they can be long-term and serious and require lifelong medications.
Petros, can I build up on that? In terms of any new approval, we have to get comfortable in managing these adverse events. We're very comfortable with GemCis side effects. We've seen that as a community oncologist. We're very comfortable with durvalumab or immunotherapy side effects. Is there any new safety data that we have to worry about with the combination? When you're talking to your patients, what are you doing to prepare them?
Great question. I think overall, if you look at the data set, there was no new safety signal, and I know community oncologists have been using checkpoint inhibition with chemotherapy across tumor types, so they have familiarity with that combination, is what you would expect to see with cisplatin-based chemotherapy and checkpoint inhibition. So it's what you expect to see with either, just combine them. The good thing is that the familiarity, of course, has been there, again, across tumor types, and as Karine mentioned, is very important to educate the patient. I think that patient education is key because you want to avoid under-reporting. Patients usually have a tendency to want to stay on treatments and may not tell you all the time what's going on. So we always tell them, you need to tell us. It's a partnership. It's an agreement. It's a teamwork here. We need to know what is happening in real time so you can adjust treatment as needed because we want the same thing, the best outcome. But that best outcome requires mutual communication, real-time assessment, monitoring, education. It's a team sport. So the advanced practice providers, nurses, pharmacists can all help, and of course the patients and the family can help us by telling us any side effects real time to manage to diagnose timely and manage properly.
ctDNA is a hot topic. Dr. Powles is going to be presenting on ctDNA pre-op and post-op part of NIAGARA trial. Your clinical implications and what to look forward to out there.
I'm very excited about the date. Actually, at AUA, I went to the microphone and I asked Josh about that. And Josh told me, wait for ASCO. So we're here at ASCO. I always believe Josh, so I'm very excited about that data. I think to me, it's very important. Mm-hmm. And I think we have discussed that before, that ctDNA is highly prognostic, has significant prognostic value. What we don't know for sure, it's predictive value, predicting benefits specifically with immunotherapy. There's hypothesis generated from IMvigor010, of course, maybe Tombola trial indirectly, Abacus trial to some degree. So there's a hypothesis about the predictive value, but we don't know for sure it's predictive value. It's highly prognostic. So interesting to see the data.
I mean, I think even not to give away what Dr. Powles is going to present, it's probably the biggest trial in muscle-invasive bladder cancer with this biomarker, pre-treatment numbers after neoadjuvant therapy, and then afterwards. So like having those time points on a trial this large, you get to see prognostically, as you're saying, who's gonna respond, how do they respond to the therapy before surgery and then afterwards. So I think if nothing else, you get so much rich information about the biomarker and its activity. I think it'll be a very exciting talk.
And congratulations to the investigators, to you, Josh, and the company who had supported that work, because that's how we learn.
Neal, before we close, again, as a urologist, your key takeaway with durvalumab now being the standard of care.
Well, I think it is game changing, and it really does now warrant that the conversation has to happen. It has to happen early on. I think the best way that patients end up seeing the medical oncologist is the urologist who's going to be performing the cystectomy tells them up front, look, I'm sending you to my medical oncology colleague because there is now a new standard of care for perioperative standard of care. And I think that helps the patient get beyond the initial, oh, you're taking my bladder out. Yes, we're taking your bladder out, but we also are going to try and do everything we can for a curative intent. And that's why you're going to see the medical oncologist, and there's a new combination therapy. And oh yes, there's only going to be a short course, 8 cycles, 8 months post-treatment. And that's how we're looking to, affect cure. So I think that for our surgical oncology colleagues listening, and the urologists, particularly in the community, this is very, very important.
Well, just before we close, to summarize here, NIAGARA trial is in fact the new standard of care for muscle-invasive bladder cancer with perioperative durvalumab and neoadjuvant chemotherapy. This is based on the advantages that we have seen from event-free survival as well as overall survival. What we've also seen is the 2-year overall survival data in favor for durvalumab with 82.2% versus 75.2%. In addition to that, we've seen ctDNA clearance higher, along with PAT-CR higher in durvalumab arm.
Absolutely, but we're also seeing this benefit across all the subsets. The 3 subsets particularly, PCR, non-PCR, ctDNA positive or negative, and also with creatinine clearance of 40 to 60 versus someone who has better kidney function. So given that, durvalumab is now the standard of care for muscle-invasive resectable bladder cancer.
Well, thank you, Josh. Thank you, Petros.
Thank you.
Thank you all.
You opened a little bit with it. We can't leave without mentioning the Potomac trial. We can't talk about the data yet. I'm proud to have led that trial with Maria DeSantis, medical oncologist from Germany, and that it's a positive trial, and that's in the high-risk NMIBC. So durvalumab will have a lot more to talk about at some future congresses. So I think it's great, and I think it also continues to add to the importance of the role with multidisciplinary team. And this is where patients, will have choice, especially for our high-risk NMIBC patients. So it's great.
And to build upon that, I want to congratulate Neal for a great job presenting the data from the CREST trial also at AUA a few weeks ago. So have Potomac positive, CREST being positive. I think it's interesting to see how we'll read this data and what regulatory agencies will do, because we may end up needing more medical oncologists working with urologists, or more urologists specializing and having the resource infrastructure to deliver these treatments.
Well, congratulations indeed. But again, cannot stress the importance of multidisciplinary, whether that's in community and certainly being done in academic setting, but especially is very much direly needed in community settings where it's not being utilized. So thank you.